so nice for you all to come out today to listen to what I have to say. I love what I do, so I love talking about all this, and you're just nice to let me bend your ear. So I changed the title a little bit, although we still will be talking about the microbiome, but I thought it's very appropriate to include but we're too afraid to ask, because all the time I run into women especially, but men as well, who minimize their GI symptoms, who don't think that bloating and diarrhea and all things GI are even important enough to talk about, and they're too embarrassed. So I thought I would just talk about a few topics that you might be afraid to ask about. So let me see if I can make this work. Okay, so the topics for today, I'm going to talk about bloating. See it literally like 3 times a day in patients. Constipation can be challenging. Fecal transplant, yes, it exists. So we'll talk about its applications because I find it so fascinating, and how it affects our microbiota. And then colon cancer screening tests, which obviously I find near and dear to my heart. So let's get it going. First question I hear all the time is, why am I so bloated and why do I have so much gas? So oftentimes bloating is a miscommunicated and even misunderstood symptom on our end. It can be the result of many things, and not just from air in the GI tract. It could be from just too much adipose tissue, mass lesions, fluid in the abdomen, but that's up to me to figure out if it's those worrisome things versus just air. It can just be a subjective symptom without there actually being a finding. Excessive gas by patients can be described as burping, belching, abdominal pain. So oftentimes patients say, I have a lot of pain with my gas. It can be misunderstood as constipation, and then obviously flatulence. So excessive gas results from a couple of pathways. A really common way is just swallowing air. When we eat, when we drink, we swallow air that results in burping or bloating. Carbohydrate malabsorption, which I'll go through, and then increased production of gas in the GI tract. So how do we swallow air? Super common. We're chewing gum, we're eating, we use a straw because we don't want the coffee to get on our teeth, we smoke, hopefully not. And then, like I said, just eating and drinking, we're swallowing air that then results in bloating, burping, and then ultimately flatulence. So just some common lifestyle modifications can result in reduction in bloating. Carbohydrate malabsorption is a little bit more complicated. So carbohydrates are basically sugars, and they take many forms, and we oftentimes don't think about a certain carbohydrate really being a sugar and vice versa, but they can be in the form of dairy products, fruits, corn syrup, soft drinks, just even table sugar, obviously, fruits and vegetables, like I mentioned. And so what these do, they serve as a substrate for fermentation, and fermentation is just the interaction of these foods with bacteria in the GI tract, and the byproduct is gas. And they serve as food for these bacteria that then propagates more fermentation and flatulence. This fermentation and then gas can then result in increased motility through the GI tract. So then increased production results in bloating as well. We produce CO2, carbon dioxide, hydrogen, methane. It's produced anywhere throughout the GI tract. It's a result of ingested foods, any and all foods, again, interacting with the bacteria in the GI tract, especially in the colon. So we have waste from our food that interacts with bacteria in our colon, and the byproduct is methane. And even bile is a common offender and cause of gas. A lot of patients who've had their gallbladders removed, they have a lot of bile circulating through their GI tract, interacts with the bacteria and results in excessive methane production. Diagnosis, are we able to give patients a reason why they're bloated as opposed to just speculating? Yes, I oftentimes will recommend keep a food journal, try to identify what you ate and how it made you feel afterwards. So eliminating certain foods from one's diet can result in an improvement in bloating. Small bowel biopsies are helpful. We now can measure levels of enzymes that are needed to break down certain carbohydrates. So we can measure lactase levels to tell you if you're truly lactose intolerant. You may already feel that way. We can also check sucrase levels. So that's the enzyme that's needed to break down the simple sugars that are present in fruits and vegetables. Again, providing you with an answer as to why you might be bloated. And then we have breath tests available. They're not perfect and they're kind of aggravating to do, but the thought is if you blow out increased amounts of hydrogen, that could be associated with bacterial overgrowth that could be responsible for your bloating. Treatment, I mean, it basically just starts with modifying your lifestyle, evaluating your lifestyle. If you chew a lot of gum, which a lot of people do you eat sugar-free mints that have sorbitol in them? Do you eat really fast? Those things, modifying those lifestyles can aid in reducing belching. There's a great over-the-counter product called FD Guard. It's a smooth muscle relaxant. It's not a medicine. It's considered a medicinal food, kind of like probiotics are. Bloating was one of the symptoms that was statistically significantly alleviated in the studies. So for flatulence, again, diet modification and diet analysis and elimination. IB Guard is the sister product to FD Guard, and it's fabulous as well for reducing bloating. Simethicone is nothing more than a surfactant. It pops air bubbles that are in your GI tract. We give it to babies. Phazyme just happens to be the high dose version that we recommend for adults. Beano is great. It contains an enzyme that we need to break down complex carbohydrates. Antibiotics sometimes we use, especially if we're worried about bacterial overgrowth. And there is over-the-counter Lactaid. Some patients don't even realize that they can eat their pizza and ice cream. They just take some Lactaid prior. It's the enzyme that we need. And we now have Sucrate available, which helps treat sucrase deficiency. You just need a prescription for that one. Just a few words on diet modification. These are common foods that can promote bloating, so I call them the sad gas foods: soy, alcohol, dairy, gluten, artificial sweeteners, sugar. Other food groups that can result in excessive bloating are the FODMAPs. And you probably, if you get on the internet and you research why you feel a certain way, all related to your GI tract, you may run into FODMAP foods. And they're basically just a collection of carbohydrates that are fermented that then result in gas. It's a pretty difficult diet to follow to the T, meaning to eliminate altogether, but oftentimes I'll give it to patients and just say, hey, if you eat a lot of one of these foods, why don't you try eliminating that and see if it reduces your bloating. So moving on to constipation, I get this question all the time: will increasing water and fiber consumption help with my constipation? And the answer, unfortunately, according to the literature, is probably not. Like bloating, constipation can mean a lot of different things to different patients. It generally is defined as a change in bowel habits, but that can range from passing hard small bowel movements, having difficulty in passing a bowel movement, straining. Patients oftentimes say they infrequently pass a bowel movement during the week, less than 3 times a week, or oftentimes they feel a sense of incomplete evacuation. It's a very, very common complaint that we see in our clinic as well as in primary care clinics. The 2 types of constipation, the most common is slow motility or slow transit. It just means your GI tract moves slowly. It has its own nervous system. It receives some input from the central nervous system, but one's GI tract just may move slower than someone else's. And then there's pelvic floor dysfunction, which I think is very appropriate for a group of mainly women, and we'll talk about why and what we can do about it. So slow motility, in addition just to you having a slow GI tract, there are other causes that can result in a slow colon, and those include certain medical conditions, Parkinson's, diabetes for sure, medications obviously can contribute to slow motility, with the biggest one being opioids. Stress, we know, sedentary lifestyle, diet, depression has even been related to constipation. So how do we treat constipation? I tell patients all the time, I can fix your diarrhea immediately. Constipation is hard, and it oftentimes is a multi-step process or a multi-visit encounter because one size doesn't fit all by any means, and it requires some dedication. But the first thing I start with is, a lot of patients say, I don't have a bowel movement every day, and I'm like, that's okay. It's okay, your colon it's doing its job. But what about the toxins? No, there are no toxins that are being cleared out by your colon. That's the job of your kidney and your liver. So I reassure patients that if you're not having a bowel movement every day and you feel good, that's okay, that's you. So a few words about dietary fiber. I said that it probably won't help your constipation if you consume more dietary fiber, and that is true. It can't hurt, but it might not fix you. We do recommend, in general, somewhere between 20 and 35 grams of fiber a day. An easy way to get extra fiber in your diet is just eating a high fiber cereal in the morning if you're able to. And then it naturally occurs in many foods. Supplements are available, they're cost effective, so if your budget's an issue for sure, which we totally understand, starting with a fiber supplement is not a bad idea. And the over-the-counter versions are psyllium husk, which is just generic Metamucil or benefiber. And then there are fruit-based fibers with a newer product called Fiber Choice, and it really is just inulin, which is a naturally occurring substance in fruits and vegetables that serves as a substrate for the promotion of good bacteria growth. So I really like that product. Objective data, so if I went to the literature and said, this is definitely going to help you, it doesn't exist. It's very inconsistent. So for me to back it up from an academic standpoint, I can't. There was one study that did demonstrate statistically significant results comparing prunes to psyllium husk. And so eating prunes resulted in 3.5 bowel movements a week versus 2.8 with psyllium husk. So again, if you want the data, eat prunes. That should help you. There is some weaker data that suggests combining water and fiber may help you as well. But the caveat is some patients don't tolerate excess fiber for multiple reasons. And they say, every time I take the fiber supplement that someone told me to take, I feel bloated. Well, yeah, that happens, unfortunately. So again, constipation's hard. There are osmotic agents that are available over the counter, and what that means is when you ingest this, what we're going to talk about, it just draws some water into your colon, and it generally does it in a way that doesn't then result in diarrhea. It just results in hydration of your stool. So a great one that I really like is polyethylene glycol. Miralax is fabulous. It's tasteless. It's cheap. We give it to babies and pregnant women and older patients. It's very effective at alleviating constipation. Just once at night is all I tell patients to take, maybe combined with a few stool softeners. Milk of magnesia is very safe. It just draws some water into your colon. Magnesium citrate might be a little bit more potent, but if you need it, you need it. Then there's stimulant laxatives. I tend to reserve these because they literally are working on the nervous system of the colon for patients who have more neurological issues like paraplegia or Parkinson's, where truly their nervous system is not what it used to be. And stimulant laxatives, again, while they work, they can oftentimes result in a lot of abdominal pain. So again, that caveat. Then there are prescriptive medicines for constipation, and they're great. They work for sure. Linzess and Amutizo, you may have seen ads or seen in the newspaper or magazines that you're reading, and those work on a water channel, a chloride and water channel in your colon to draw a lot of water into your colon, like a lot, to the point of stating that you will have diarrhea if you take this. And so again, it's really a matter of working with your provider to figure out, is that the right medication for you? And some patients do need it. Trulance is a nice alternative because it works on a chloride and water channel in the small bowel, so the incidence of diarrhea is a lot less. Then we have Motegrity and Movantic. These are a little bit more sophisticated, with Movantic being used in patients who suffer from constipation related to opioid use. And then just a few words on pelvic floor dysfunction. So in order to have a successful bowel movement, it requires the coordination of your pelvic floor muscles. And so it requires relaxation of the pelvic floor so that the rectal angle, and I have a picture in a minute, elongates. When we're standing and when we're sitting, literally your rectum is at a right angle. And so if you have dysfunction of your pelvic floor muscles, instead of elongation of your rectal angle occurring, it actually becomes more acute. It becomes more like that, and I'll show you what I mean in the picture. So it truly, you will bear down, and instead of it elongating, it tightens up. So and it happens. So and really, I find this appropriate to talk about with a room of women because a lot of us have had children, and one of the most common causes of pelvic floor dysfunction is obstetrical injury. So here's a nice demonstration. So when we sit on the toilet, our rectum is truly at a right angle. We were not meant to sit on a toilet. We were meant to squat, because when we squat, our rectal angle elongates. And the little black slingy thing is the muscle that, in the setting of pelvic floor dysfunction, tightens up that angle and makes it more acute, so that all you're doing is bearing down and bearing down and bearing down, and you're not able to pass your bowel movement. So that's where the squatty potty literally comes into play. That product is genius. It enables one to literally squat while sitting. It raises your legs, it elongates that rectal angle, and allows you to have a successful bowel movement. So next question, is there such thing as a fecal transplant? And the answer is yes. It's called fecal microbiota transplantation. Currently, it's only approved for one clinical scenario, and that's C. diff infection. A lot of you, if you work in healthcare, or it's so common now, you may have had a friend or a loved one who suffered from C. diff diarrhea. It's a big deal. So why are we using fecal transplant as opposed to antibiotics in the setting of this one infection? Well, it's a loaded question. So the GI tract is the site of a complex community of microorganisms, and these microorganisms that we are learning other organisms are living with other organisms, they exist in harmony with the host. Even like your cat has its own microbiome, and your dog, and the fly out there has its own microbiome. And we call this community the human gut microbiota. Actually, when we say microbiome, we're referring to the genes of those organisms. Anyway, it's just words. But our GI tract has at least 10 to the 14th power bacteria, which is like trillion, gillions, I don't even know where that takes us. And we're studying what bacteria occupy our colon and elsewhere in our body through a project called the Human Microbiome Project that's been going on for over 10 years now. We're learning that the microbiota plays very important roles in our body. They're pretty complicated, but you can see it helps us make vitamins, it helps us metabolize our food, it plays a role in host cell growth and promoting new blood vessels to grow. It plays a role in our bone density. It's been implicated in disease states of basically every organ system in our body. Literally the only thing on there that's not on there is the kidney system, the renal system. So it's very exciting that we're learning its role, although every pathway hasn't been totally defined. So your microbiota, we all have one. It's influenced by many factors. How you were delivered. Did you have a C-section? Did you have a vaginal delivery? There's important bacteria in the vaginal canal of a woman that then populates on a baby. Were you breastfed? Were you bottle fed? Your age. We know that when you're young and you're very old, your populations are low. They peak at middle age and then, like I said, decline. Occupation and exposures and where you live. Our microbiome is very different from sub-Saharan African people, and that's been demonstrated in many, many studies. So then back to fecal transplant and C. diff. So antibiotics, which we use often, for better or for worse, can selectively kill off our good bacteria that help protect the colon mucosa from invasion from pathogenic or bad bacteria. This imbalance results, and it's called dysbiosis. And it ends up leading to an overgrowth of bad bacteria. In this case, in which we use fecal transplant, it leads to an overgrowth of C. diff, C. difficile. And it results in a terrible, terrible, nearly wasting diarrheal illness. And we're seeing it more common in the hospital, but we're also seeing it very often in the community. So the two common types of bacteria become obliterated, nearly obliterated in the setting of C. diff. They're the most common, though, in a healthy colon and healthy stool. So when we go in and truly spray someone else's donor stool into the right colon and transverse colon, it repopulates that colon's bacterial environment with these two common genuses, and ultimately curing C. diff. And there truly is a nearly 100% cure rate of C. diff after transplant. The GI literature, in my opinion, it may not be yours, is full of potential applications for a fecal transplant, and it will be exciting to see how we use it over the next 10 to 20 to 30 years. In our world, we think it's going to take off. In particular, they're looking at its role in inflammatory bowel disease, so Crohn's disease, ulcerative colitis, infectious diarrhea, even IBS, antibiotic-associated diarrhea. We wonder if it can help obesity. There have been studies in mice, I think this is so fascinating, where they take the stool from an overweight mouse and put it into a thin mouse, and that thin mouse becomes overweight. We cannot explain it yet, but it has happened in mice. Now, these are mice. So anyway, we wonder if it's going to play a role in treating autism, autoimmune disorders, diabetes, and metabolic syndrome, and small bowel bacterial overgrowth. But just a few words about dysbiosis. So you can have dysbiosis and symptoms and not have C. diff. So you can have an alteration in your bacterial environment that may be responsible for your symptoms. And so just to remind you from a slide before, dysbiosis is an alteration in your microbial community. You have a reduction in your good bacteria, allows for pathogenic bacteria to overgrow. Do we have a way of measuring all that in you? No, not yet. Yes, you can send your stool away and have it analyzed. Am I able to interpret those results yet? No. It's coming, it's definitely coming, but I don't have a way of interpreting it yet with any validity. Causes of dysbiosis, number one is medications. Just like I pointed out, antibiotics result in C. diff, which is a prime example. Steroids, antacids, nonsteroidals, and chemotherapy. Diet plays a big role in dysbiosis. So low fiber, high fat, high sugar all alter the bacterial environment of our GI tract. And then we know alcohol and artificial sweeteners also play a role. What are the symptoms that we think are related to dysbiosis? I mean, basically everything I see all day long: abdominal pain, bloating, diarrhea, constipation, joint pains, brain fog, headaches. And the latter being, we think this alteration in the bacterial environment leads to, well, what you'll read on the internet is leaky gut. We call it increased intestinal permeability, where then the GI tract allows for the crossage of, or the passage of, I hate to use the word toxins, but things that shouldn't be in our bloodstream that then can cause downstream reactions and inflammation in your joints, some brain fog, headaches, that sort of thing. Again, the pathways are not fully there, but we've got animal models that have proven them. And then dysbiosis, again, we think it plays a role in the modulation of certain diseases, and just to name a few: IBS, yeast infections, autoimmune disorders, obesity, acne, depression, heart disease, food sensitivities. So what is the solution to dysbiosis? If you think, oh yeah, I take Prilosec every day and I feel this way, I feel bloated, I have diarrhea, could you have dysbiosis? Yes. Do I have a way of proving it? Not yet. But what could you do to try to make yourself feel better? So one, remove the offending agent, replace, and restore. And I'll go over those in the next slides. So removing the offending agent, can you not take that antibiotic? We all think that we are using antibiotics probably a little bit too freely. Should we stop and take a second guess at it? And the answer is definitely yes. Are you able to wean off of your anti-acid medicine? Do you really need it, or are you able to modify your lifestyle? What about replacing? So I get this question all the time: should I take a probiotic? Probiotics are defined as live microorganisms which, when administered in adequate amounts, confer a health benefit to the host. I mean, the problem is, what is adequate amounts? We don't know that yet. So there are many choices over the counter. The ones I tend to like are VSL number 3 and Culturelle. They've been demonstrated to aid in alleviating symptoms in studies, so those are the ones I tend to promote. The limitations, though, are we don't know what the adequate amount is, and then there are just so many undiscovered species of bacteria that we haven't captured it all in one pill. And one pill can't give it all to you. It can't give you every species you need. So I tell patients, if it fits your budget, yes. We do have data that suggests that it helps with diarrhea, so I say if you have diarrhea, yes. Constipation, I'm not so sure. Again, if I just look at my data. So I tell patients, it can't hurt you, I just can't guarantee that it'll help you. Other ways to restore your bacterial environment back to kind of where it should be is really, it's all your diet, truly. And then maybe will fecal transplant be used in the future for symptoms? We tend to promote a plant-based diet, plant-based fiber, whole grains that are low in gluten. We think these whole grains serve as food for the good bacteria. That's kind of where that whole prebiotic term comes from. And then obviously, we're all trying to limit our sugar, gluten, and dairy intake. And the last topic and the last question is, do I have to have a colonoscopy? And the answer is absolutely. At some point, yes. So colon cancer is the second leading cause of cancer deaths in both men and women in this country. There's about a 4% lifetime incidence in people of average risk. Men have a slightly higher, I mean, I'm talking like 0.4% higher. So we basically say women and men are affected equally. There's a higher incidence, though, in African Americans, Indians, American Indians, and Hispanics. Just in 2018 alone, there were 140,000 cases diagnosed with 50,000 deaths. Most colon cancers occur after the age of 50, but polyps and cancers nowadays, which we'll talk about in subsequent slides, are being found at younger ages. And then obviously with any cancer, it increases with every decade after the age of 50. And we think it's just exposure. You're exposed to more pathogens and carcinogens, and then just the normal aging of the colon. What are your risk factors for colon cancer? Family history is a big one. Big one. So a first-degree relative who's had colon cancer certainly is a risk for you developing colon cancer. And then anyone in your family's had what we call an advanced polyp. So a big polyp or a polyp that has not just kind of bland and benign pathology. Your own personal history of polyps. So if you've already had your colonoscopy and you were told you had precancerous polyps, you need to follow your doctor's advice and come back for your follow-up so we don't miss any that theoretically could turn into cancer. Age, like I said, there are certain conditions, genetic conditions, as well as inflammatory conditions such as Crohn's and ulcerative colitis that place patients at an increased risk of colon cancer. Smoking is just, we know that. I mean, it increases the risk of every cancer. Other factors that we think may be playing a role in colon cancer, but again, we haven't proven definitively, would be diet, red meat in particular, alcohol use, type 2 diabetics, and obese patients tend to have a slightly higher incidence of colon cancer. So I mentioned that polyps are a risk factor for colon cancer. What is a polyp? So it's a growth of tissue in the lining of the colon. Colon cancer starts out as a polyp. It is the precursor lesion to colon cancer. And we think on average it takes about 10 years for that polyp to then turn into a colon cancer. So how do we look for a polyp? Well, we institute a colon cancer screening test. And so the goal of any screening test, like a pap smear or a mammogram or a PSA for men, is to detect disease when one is asymptomatic. And in the case of colon cancer, it's detecting precancerous lesions, again, that polyp that I've mentioned, and the ones that we worry about are adenomatous polyps. And then we want to detect, hopefully not, but we do it all the time, an early colon cancer in an asymptomatic patient. The guidelines for when one should begin colon cancer screening is in a little bit of a limbo stage right now. Oncology guidelines are recommending that one starts at the age of 45. Our guidelines have not yet changed. And as a result of this, which hopefully will be resolved soon, insurance companies haven't quite caught up. For Aetna is the only insurance company here in this area that will cover a colonoscopy, an average risk screening colonoscopy at the age of 45. So if you have Aetna, which I did, you can have your colonoscopy at 45. For everyone else, for right now, it's 50. I think it's going to change. And for patients who do have family histories of colon cancer or polyps, you start earlier. I won't get into the fine details of that. It's just a matter of talking to your doctor or talking to a gastroenterologist. So why has the age dropped down to 45? Well, it's because in patients under the age of 55, there's been a 51% increase in the incidence of colon cancer. And with that 51% increase in incidence, there's been an 11% increase in death from colon cancer in these patients. So 40-year-olds are developing colon cancer. I just scoped a woman the other day for totally unrelated reasons. She was 34, had a 1 centimeter polyp in her sigmoid colon, and centimeters are a big deal. So 1 centimeter is actually a big polyp in the world of polyps. And in 10 years, again, we said that it takes 10 years for a polyp to grow into colon cancer, she would absolutely have colon cancer. So it was just kind of crazy luck that we did the colonoscopy and found it. So it's real. We are finding colon cancers in younger patients. And what's encouraging is that mathematical modeling now is suggesting that over 5 years, if we start at the age of 45, the incidence of colon cancer will be reduced by 29,000, and deaths from colon cancer will be reduced by 11,000. So that's real numbers. So what are the tests available for colon cancer screening? Like I mentioned, it's the colonoscopy. We think it's the preferred screening test. It allows for direct visualization of the colon. It allows for not only detecting the polyps, but also real-time removal of the polyps. We recommend that patients, if you have a normal clean colon, no polyps, that you undergo a colonoscopy every 10 years, and then every 3 to 5 years if polyps are removed. And those times are a little bit different if you have a family history. And what's even more exciting to me, is that we finally can say that a colonoscopy can save your life. So there was a study that was put out a couple of years ago that revealed that doing a colonoscopy and removing that polyp in you in turn reduces your risk of dying from colon cancer by 53%. So for a long time we thought, oh hey, this is going to save your life, but we didn't have the data to back it up. We now have the data that says this will save your life if we remove a polyp. Love it. So how do we perform a colonoscopy? I mean, on the left is just a cartoon of a colon. That's the colonoscope that we pass all the way around to the right colon. As I remove the scope, taking a good look for polyps. That's a polyp on the right with a snare that we burn off and remove and send to pathology right then and there. So what if you just don't want a colonoscopy, or you can't take time off from work, or if a patient's, quote, maybe a little bit too sick and is apprehensive about being put to sleep? Then there is a nice non-invasive stool test that's come out over the past few years called Cologuard. And it requires a stool sample that you mail in. Yes, you mail your stool in. And the test detects blood as well as DNA that is shed from a polyp as well as from an early colon cancer. It's a very good test at detecting cancer. It's not so good at detecting polyps. There's only about a 42% detection rate for polyps. So they always make me a little bit nervous because I'm like, we don't want to find those colon cancers, we want to find the polyps. But again, if it's the best we got, which is still pretty good, I'm okay with it. So, and the other thing is there's a pretty decent false positive rate. So oftentimes, patients will come in and we don't find anything, and that occurs about 13% of the time. So it can cause a little bit of stress. So you're saying you don't want to have your colonoscopy for whatever reason, but then you do this test, you've got to wait, a week or 10 days with the possibility of polyps or colon cancer. So it can create some stress. Other outdated screening tools that you may read about if you search would be fecal occult blood testing, barium enema, Flexigs. We're not doing those anymore. So timing on colon cancer screening, and this is really when to stop doing colon cancer colonoscopies, and it's debated in our literature. We do say if you've never had one and you're 75 or 80 and you're in overall good health and you've got about 10 more years of living, you should definitely have one, absolutely. What do I say to patients when they're 80 and they come in and they have a clean colon, and again, they're relatively healthy, and we say, you probably have 10 more years of living, then I'll say, let's think about it. So it's a very individualized decision. It's one you should talk about when you approach those ages with your doctors to make the right decision. So how are we doing with screening? In Tennessee, patients who could be screened, we're only screening about 67%. And the goal is 80. And we know from mathematical modeling that if we were screening 80% of the available population, the incidence of colon cancer would be decreased by 77,000 and deaths would be reduced by 31,000. So we're not doing good enough. So it's hopefully a matter of us talking about it and not being afraid or embarrassed to seize the moment and drink your Miralax prep. But really, how I want to end this is just discuss with your physician the timing of colon cancer screening. You'll figure out which one is best for you, but obviously I'm going to promote the colonoscopy. It's really not that big of a deal. I can tell you from 2 weeks ago, and it could save your life. That's it. Thank you very much. I appreciate it. Yeah, that's a great question. So here at Williamson and a lot of places around here allow for what we call open access. So I'm really busy and I'm pretty healthy, and I didn't want to go sit in clinic just to talk to the gastroenterologist who was going to do my colonoscopy and review my medication list that doesn't exist. So we do allow for patients just to sign up for their colonoscopy, and I or whoever meets you the morning of and talks to you, answers any questions, and then you have your colonoscopy right then and there and you move on. So most of the time a clinic visit is not required. If you're sicker and you're on blood thinners, or you have diabetes or high blood pressure, and we want to talk about the prep and is it going to drop your blood sugar, or do we need to stop your blood thinners? Yeah, we require you to come in. Right, and everybody's insurance is a little bit different, but we're finding that most patients can have an open access colonoscopy, again, if they're healthy. So, yeah. That's so interesting, and I need to learn more, and I'm trying to read more about it. I think the idea is that yes, giving your GI tract a break does allow for bacteria to kind of recover and have a moment, and I think so I haven't seen any benefit. I haven't done it, and I don't really advise on weight loss per se. But I think the idea goes back to like when we were living on the prairie and living in, you know, wherever we came from, and we would eat when there was just food. I mean, there wasn't always food. The issue with our society is that we have so much access to food, and is that healthy for our GI tract? So I did read one thing that did say in terms of weight loss, it was no better than other programs per se. But the concept is fascinating and interesting, and I have friends who've tried it. So the only setting in which one should have a colonoscopy related to diverticulitis is after an attack of diverticulitis. We just want to clarify and make sure there's nothing else in the colon that can mimic diverticulitis on a CT. So when we look at a colon and the diagnosis is diverticulitis, it's just as inflamed and thickened, and there's stranding, and we really want to go in and make sure that thickening is not a cancer. I've had one patient that we thought it was diverticulitis and it was a colon cancer, and we want to make sure it's not Crohn's or ulcerative colitis. So that's really the only time. It's not like, oh, you've had a diverticulitis, now you need one every year. No, there's nothing like that. It's more after that episode. We just like to clarify. Oh, that's where, when I mentioned the whole leaky gut thing and increased intestinal permeability, that's where we think maybe gluten-rich foods play a role in kind of damaging the lining of the GI tract. We think that sugars feed abnormal bacteria that then can damage the lining. So there's theories, again, no pathway has been clearly defined. We still don't fully understand what causes ulcerative colitis and Crohn's. And it's an autoimmune disorder, but we don't know what triggers that autoimmune event. Is it an environmental issue? Is it food? We don't fully. Is it family history? You know, we don't know. I know it's frustrating. Well, no, I mean, we're working on getting 45 approved in the GI world. Oncology has made a statement, and it's in their recommendations, 45 for sure, for sure. And I'll do it in a 45-year-old, absolutely. It's just an insurance thing. I can't control them. But if you've got Aetna, you can have it. And we're checking all the time.